When we have a patient that presents an area with extremely fragile tissue, thin biotype, no attached gingiva, keratinized gingiva, and on top of that we have a high frenum pull, a frenum that is pulling from the tooth down from the gingival margin. Those areas are more prone to recession, especially the patient already presents an existing gingival recession, an existing gum recession, and the patient is ready for orthodontic therapy. An evaluation is in order to prevent further progression of the thinning area of gum recession or attachment loss. So for all those orthodontists, prior to orthodontic therapy, if you see a tooth that already has thin biotype with an existing progression of recession and a high frenum pull, a periodontal evaluation is advised to provide an area of attached gingiva, eliminate the frenum pull, and if possible achieve root coverage prior to orthodontic therapy. So on patients that require orthodontic therapy, if you see these three things, thin biotype with existing recessions, no attached gingiva, and a frenum pull, definitely that patient will require a periodontal evaluation. What we want to achieve is provide a band of keratinized tissue or attached gingiva and root coverage on those areas that have already existing progressive recessions. It is definitely best if you treat these areas with progressive recession or no attached gingiva or areas that present high frenum pulls, especially in the mandibular anterior area, prior to orthodontic therapy, not during orthodontic therapy. Although I have had many cases of patients sent to me during the orthodontic therapy after the orthodontic therapy had been started due to the presence of progressive recessions that began shortly after the orthodontic therapy started. Sometimes these high frenum pulls are not properly checked during the initial evaluation, and they can become a problem during orthodontic therapy, especially if the orthodontic force is applied too fast, too quickly with a high torque. My advice is to eliminate those areas with high frenum pulls prior to orthodontic therapy and provide definitely a band of keratinized tissue on those areas that present thin, fragile tissue with an existing recession, gum recession. Those areas, especially in the lower mandibular anterior teeth, which present thin gum tissue, thin gingiva, and existing recessions, are definitely very much prone to recession, progression recession, if the orthodontic therapy started with high torque and is done very fast. Eliminating those high frenum pulls prior to orthodontic therapy will minimize the potential problems that the orthodontist may have during the orthodontic therapy. And like I said earlier, if the orthodontist detects any area of progression of recession during active orthodontic therapy, the first thing that needs to be done is stop the orthodontic movement and have a periodontal evaluation. The need of a gingival graft may be required, especially if the attachment loss is progressing and the recession is getting worse. Ideally, you want to minimize these risks at the very beginning and do any necessary grafting prior to orthodontic therapy, not during orthodontic therapy. The use of free gingival grafts or epithelialized connective tissue grafts is possibly the best option for the mandibular anterior area when we want to provide a fast band of keratinized tissue, of protective band of keratinized tissue on those areas that present thin biotype, thin tissue, and existing recessions. The morbidity associated with the harvesting of a free gingival graft is a minimum. Think about this. The growth of the epithelium, which is the superficial layer of the site where we harvest from, grows at a speed of about 0.5 millimeters a day. Usually free gingival grafts are 0.7, 0.8 millimeters in thickness, under 1 millimeter. The speed of growth of the epithelium, which covers that wound, is about 0.5 millimeters a day. So we are to expect a full coverage of the donor site where we harvested the tissue from, which is the palate. We are to expect, like I said, a full coverage of that area with epithelium within the first 2 weeks. Between the first week or two of healing, the donor site should be pretty much covered by epithelium again at this rate of growth. Obviously, this depends on the size of the free gingival graft. Sometimes we need to harvest a bigger piece. But again, the morbidity of this type of procedures is extremely low, and it's totally worth it because it provides a high quality tissue on those areas that are most needed, on those areas with progressing recession and lack of attached gingiva in a very short period of time. So within the first week or two after harvesting that little tiny piece of less than 1 millimeter thick gingival graft, we're going to see that the epithelium is already covering the site. Because again, the epithelium grows pretty quickly at a speed of 0.5 millimeters a day. I haven't personally seen any significant differences between epithelial growth or the speed at which the epithelium grows between ages 50 and above or under 50 years of age. So the epithelium likely is a tissue that we can reharvest again and again because it grows and heals very quickly. It's the protective layer of all our body, and as such, our body is predetermined to quickly regrow that superficial layer of epithelium. To prevent the initial discomfort that the patient may have on the roof of the mouth, on the palate, we can advise them to wear a little bleaching tray to protect the donor site where the tissue was harvested from. This will eliminate the contact of hot or spicy foods that the patient may have during the first week of healing. After that, nothing is required. So the donor site is exposed to the saliva. The healing properties of the saliva will enhance and speed up the healing process of the epithelium, which will cover that area, like I said earlier, very quickly. We can inform the patient that the donor site, the palatal area, can provide us with a lifetime supply of tissue, of gingival tissue, for future augmentation procedures and gingival grafting.